Right, hello everyone. Welcome to the Test Him podcast. This is a very special episode, not because Toby's not here. It's very special because we got two very special guests in the studio with us today. Welcome, Mr. Tim Child and Mr. Jonathan Ramsay. Thank you very much for joining us.
Yeah, thank you for having us.
We're going to have a conversation about sperm DNA fragmentation today, and it's the idea is really to, in some ways, we've got two sides of the camp here because, you know, Tim, obviously a gynecologist, and you work with the HFEA, you work with the traffic light system and a lot of research and data. And then obviously Jonathan, you know, fantastic expert urologist and specialist in male fertility. So I think it's the idea of today is just to have a discussion about sperm DNA fragmentation, because I think, and why we wanted to do this, I think, is for the patients, because they hear mixed messages, don't they? As patients, oh, you must get a DNA fragmentation test done, and therefore you need to do this, that, and the other. Mm-hmm. And then maybe they go into their clinic, and the clinic said, "Don't bother. It doesn't make any difference. We're not going to do anything differently with that result." So I think it'd be really good to explore that, so that the patients can understand the discussions and the arguments to and for, for and against from both sides. And I also want to open up and say that we're talking sperm DNA fragmentation today, but importantly note that that's only one test, and it has to be taken into account with the whole history and actually a whole load of other tests. Because I think what we're seeing on social media and a lot of discussions amongst patients, and I don't know if you two have experienced this, patients are saying, okay, well, I want to have a DNA fragmentation test. It's like, okay, but you need to also consider oxidative stress, ultrasound, varicocele, infection. So I think we need to make that point really important as well.
Yeah, it's about appropriateness, isn't it, of that recommendation at the right time.
Yeah. So I've got some questions in mind. I've shared some questions with you both. Who knows where this is going to go? But I guess what would be an interesting starting point is perhaps you both give your overall view of where is DNA frag in terms of your view in terms of within the industry. So perhaps Tim, from your point as a gynecologist and what you see in clinics, and then Jonathan from your side. So off you go. Let's open it up and see where it goes.
Okay, great. So I think it's always been felt that there's not enough testing that has been available on the male side, and traditionally, for all sorts of different reasons, the testing has been female focused. Partly, perhaps that's because traditionally fertility clinics have been within the gynae clinic setting rather than the urology setting. And I think it's been a fair criticism that on the male side, people have done just a routine semen analysis, and then things have stopped at that point. So there is a need for more testing. Obviously, sperm DNA fragmentation is one of these potential tests that can be done. And I think the debate then has been, well, what is the place of sperm DNA frag testing? Should all men have it who are in a fertility clinic, or should it be narrowed down to certain situations, which we'll get into later on? Yeah. So I guess my sort of opening view would be, yes, there is an important place for a test such as sperm DNA fragmentation. Is it absolutely clear cut who should have it, who shouldn't have it? No, it isn't, which is why then you get this mixed messages that patients are receiving, because in the end, none of us really know for sure, in my opinion, who definitely should and who definitely shouldn't have it.
Yeah, I think that's a really important point, and perhaps the need for very clear guidelines, and perhaps that they're missing. I don't know. So, Jonathan, over to you. Kind of, what's your opening view from your side of the camp?
Well, I largely agree with Tim. I think that's a very reasonable view of where we are. I suppose where I come to this is from the point of view of diagnosis, because traditionally we've not really gone in for much diagnosis in the whole subject of fertility, and particularly not male fertility, because the solution has seemed to be IVF and ICSI, which has, of course, traditionally succeeded. Certainly not for everybody, but it is what the patients want, a baby. And therefore, we have confused, I think, in our minds, diagnosing the problem with treating the problem. And if you're sort of down there with the patients all the time, as I am, and if you come from the stem of urology, which after all is about diagnosis, then you can't get away from the simple fact that very often, most often, with male factor infertility, whether idiopathic or unexplained, we don't get a diagnosis. And possibly the whole business of having a diagnosis, in inverted commas, which is titled unexplained, actually tells us that there is a problem with an absence of diagnosis. So I come to this trying to diagnose a problem, firstly, to advise the patients better, and secondly, and this is the point of debate, to get a better outcome. So it's all, to my way of thinking, this is about diagnosis. And with diagnosis, often, not always, comes an explanation. And patients enjoy having an explanation, even if that explanation is resulting in what they fear, which is that indeed they cannot have a baby.
Well, I think it's that fear, isn't it? It's sometimes the fear of failure, of not being able to conceive by having diagnostics in the first instance. But I think when you're sort of managing emotions, it's got to be about managing expectations. And I think a diagnosis, a true, proper differential diagnosis, can really help with managing those expectations of potential outcome. And then looking at what options do patients have for their fertility journey, and there's many options, isn't there? So I think that's a really good starting point, really.
And of course we see that guys that have a high DNA fragmentation test, and so this one perhaps to you, Tim, is that if they have that within an IVF clinic, they have a test and they get that diagnosis, I think the course of treatment then is they're not sure where they go with that. And I think sometimes is it true that the clinics then is like, okay, well, look, we're going to do ICSI, or they use what tools they have rather than perhaps saying, okay, Jonathan, you're saying, okay, it's a diagnosis, we need to look a bit deeper. Is there that issue within IVF in that sense, do you think?
I think it's probably an issue generally, because I completely agree with Jonathan that understandably patients are looking for a diagnosis, and in the end, if you're looking at any test, whether it's male, female, whether it's outside of fertility, whatever it is, the important thing beforehand, in my view, is that it's fine to do a test and to get a diagnosis, but it's very important that result of that test lets you change the management in some way, whether that's lifestyle or supplements or whatever it might be, to actually improve the outcome. Because if there's a test which is purely giving someone information, but it doesn't change the outcome in any way, there might still be benefits in doing that test because the patient feels happier about it. But if it doesn't actually change the outcome in any way, then it's of questionable relevance potentially. And I think that's where, in terms of what fertility clinics or IVF clinics might do with the information from the test, that is where I think for a lot of it is a bit of a black hole at the moment, that if the test comes back as abnormal, this isn't just sperm DNA frag, there's other examples as well. If it comes back as abnormal, that might well be a diagnosis, but in terms of what does a clinic do with that information, and that's where there's a lot of differing views on it, and there's a lack of research in general, I would say.
Yeah.
Yes, because it's jolly difficult to get that research, because research in fertility has generally relied upon big data, and big data retrospectively, or big data with a meta-analysis, so putting lots of papers together, or even an umbrella study, which is a meta-analysis of the meta-analysis. Now, of course, this usually results, quite rightly, to outcome. So the input might be DNA fragmentation, might be just a semen analysis, and the outcome might be a pregnancy, a clinical pregnancy, a live birth. But of course, that sort of data need not necessarily, and in my view doesn't often relate to the individual. So the question really is, if we improve, let us say, the DNA fragmentation in an individual case, given the female factors, do we raise the chance of a better outcome in that individual, despite the fact that if we take 1,000 individuals and just look at the outcome, it might not be related to the thing we were seeking to change. So this is a difficult thing to handle, I think, particularly for us in fertility, because unlike any other branch of medicine, quite apart from anything else, we're dealing with two people.
And you've got two multifactorial issues that could be going on in a couple in order to try and conceive. But if we're only focused on one side and doing quite a lot of investigative work on just the female side, for example, then we may be missing a whole rack of information that is equally as valid in trying to bring the two gametes together. So,
and this is nobody's fault.
No.
I mean, once again, as Tim and I find often, you might do an intervention, whether it's a female intervention, it might be treatment of endometriosis. In a man, it might be treating a varicocele. They have another cycle where they failed two before. Now, to know whether or not you increased their chances because one of those embryos resulted in a live birth, you might have to wait for 2 years.
yeah.
And the attention span of all of us, whether it be a fertility clinic or an individual doctor, to get that data is really tricky. I mean, I've tried in one clinic, and you would have thought that we could have got that live birth data from 500 cycles. But of course, when you're dealing with small margins, you've only got to miss the data from 5 couples, and your answer is frankly invalid.
Yeah.
So this is a very difficult thing to do.
It is, and I think this is it, really. It's about trying to ensure that we take as much care for both, parts of the couple, really, in understanding what's going on, from a diagnostic point of view, and a diagnosis from those diagnostics that are available to us. And I think some of the complications that I see is that there is a differential when we see patients out there. There is the NHS and then there is the private sector. And unfortunately, some of the diagnostic tests, both male and female, in fairness, are not necessarily available for all patients within the NHS. I don't know if there's any comments there that we should think about that from that point of view.
Yeah, I suppose the NHS, can probably quite rightly, the testing that should be done might be driven by NICE guidelines, etc. And they, I think, probably quite rightly, are fairly evidence-based. And I think as the evidence rolls out, hopefully completely in favour of more widespread DNA frag testing and then management change after that, I can imagine testing coming into the NHS more. But you're quite right at the moment. I think one thing is, from an IVF perspective, I think in the UK last year, about 65% of cycles were privately funded. So unfortunately, fertility generally has been pushed out into the private sector away from NHS anyway.
And of course, you might think that's a very important point that Tim's just made, because this is a fact of life, 65% or even more in the private sector. Now, you might think that in the private sector, where one has the ability to do extra tests, whether they be male or female, one might think, oh, well, this is the place where we'll get our prospective data. But of course, you're even less likely to get it in the private sector, because when I'm seeing a couple and let's say it's unexplained male infertility and there is a high DNA fragmentation and we elect to treat the varicocele, what I cannot do is to say, I've got a great idea, you two. We're going to toss a coin. If it's heads, we'll repair your varicocele and do another cycle, and if it's tails, we'll just do another cycle. So they say, we've not come for you, chum, to toss a coin. What do you think?
Yep.
Now, of course, all of us doctors, Tim and I know doctors, we know our tribe. We don't want to upset our patients. We don't want to force them unwillingly down a track. Really, really difficult, therefore, to get that prospective data, whether actually it's in the public sector, where often the couples are up against time. They've waited for their cycle, and they don't want to hear somebody saying, good idea, we're just going to treat your varicocele and then wait 6 months. So it's so difficult to get the prospective data on which NICE and the HFEA, and we can all feel entirely comfortable and confident about it.
So how do we move things forward then? Because sort of, Tim, you're saying, the data, we haven't got the data. How, that's what's leading to some of the questions over whether to do the test or not. And obviously, Jonathan, you just explained the problem with trying to get the data. It kind of almost becomes a bit of a stalemate, does it? How do we move forward so that actually more patients are perhaps having these tests and it's influencing their treatment? Or how do we change things?
Well, I mean, I think there are. It is possible to do trials, and sort of an example of the ERA testing, which was a type of endometrial receptivity assay testing obviously on the female side, which had been brought in by a company that said basically everyone should have it, and then it actually was an American IVF group that did a big study on it, showing that it didn't help. In fact, it even made things worse. So it is possible to do for private groups, but I agree it's difficult to run these sorts of trials. Or there are some big NHS funded trials that look at PIXI, which is something which is added onto ICSI. That was a huge trial, and that was actually state NHS funded in the UK, which changed practice worldwide. So it is possible, but you need someone or a group of people to really want to drive that forward. And I'm sure at some point that will happen. And essentially, what would happen, the trial probably would either be that people coming into a fertility couple would be either randomized, flip of a coin, to either half the men have testing, half don't have testing, and then you just look to see in an agreed way of what do you do with that result, and then you look to see are there more babies born in the half that had testing compared to the half that didn't have testing, or you do it where everyone has testing, but in only half of them is actually the result used to actually change management, and that's what they did with the endometrial receptivity. That's how they ran that trial, actually. So there are different ways of doing it, but these are expensive trials to do. In the pharmaceutical world, then it's worth doing these trials because obviously you can then sell the drugs for lots of money. The pharma companies sell them for lots of money. Whether you guys as a company are going to be wanting to fund a big trial like that, because it's very, very expensive and they take a long time, as Jonathan suggested.
Well, I think one of the considerations there is doing that type of research quite often doesn't actually lead to a medicine that could be prescribed, because sometimes it's just a test that could be a differential diagnosis to whether a patient should receive a varicocelectomy or not, an embolization. So companies don't necessarily, if they're just in that diagnostic field, get any benefit from the management of patients based on the outcome of that result. And so I think there's always going to be a catch-22 of should we invest, should we not invest? I think my view is that we should definitely invest and work collaboratively to find better data and data that can help with the management of patients long term. But there's got to be a bit of a trade-off, I think, to see how we can do that robustly and effectively and get, a multitude of players to come in and say, actually, should we do that because it's probably the right thing to do? And my view is the more data that we have, the better the way in which we can shape our thinking, our education, and an awareness of whether these tests are valid or not valid. And I think I've tried to do that, actually. I've tried to look at, should we just test, the next 100 patients, not change the management, but let's just look at the outcomes and see whether there could have been an intervention based, retrospectively on those outcomes. So I'm quite happy to throw my two penneth in the ring and say, let's try and do that. But I think we've got to work collaboratively with like the HFEA or organisations and maybe the NHS to see if we can get funding to fertilise the ideas and see whether it's a valid thing to do.
Well, of course, the area that we're really talking about is unexplained infertility, for research and also to be a little bit more positive about the benefits, because unexplained begs, let's explain it. And if you can explain it by a measurement, and let's take varicocele, then of course we're off to quite a good start. And if you can then measure the effect of what you've measured the varicocele, so it's not just that it's there, but you've measured it. So you can measure the effect either by semen analysis, but I would argue with DNA fragmentation before and after, because in answer to Ian's question, that's what I do. So we take a measurement of a varicocele, we explain the male factor. There may be a normal semen analysis or an abnormal one. We know the DNA fragmentation is deranged. We treat the varicocele having measured it, and we remeasure the fragmentation. Now, the trouble with this compared with the ERA test or the excellent national survey in PIXI for DNA fragmentation is that there is that time lapse. If you're trying to measure something in the laboratory, that doesn't delay the treatment cycle, which is what our patients want and need. But with varicocele, of course, there is this delay, and that's tricky. So, with a bit of education, primary care, that sort of trial could be done up front. So you identify the varicocele, you look at the fertility, often right at the beginning of a couple's journey. And then the 6 months, because it really is 6 months to get the improvement, doesn't matter so much. And then the randomization doesn't matter so much because we've got time on our hands. With younger couples, possibly with younger female partners. So if we were looking at the unexplained infertility trial, you'd start right at the beginning. The difficulty, however, is that their infertility by definition has not been proven.
No, absolutely.
So you're taking, as it were, fertile, naive couples and doing something to them. Tricky with the ethics.
Yeah.
But it would get over the time frame problem, which is really tricky once we're in the fertility unit, isn't it, Tim?
I agree. And I think another issue in the area is obviously the fairly wide range of assays that are used. So when people talk about sperm DNA fragmentation, well, that's a multi-headed thing because how is it being
Excuse
measured?
the pun.
How is it being measured? What's the reproducibility between the different assays that are used? And that has absolutely, of course, hampered research in this area.
And that's a big argument. That was something I wanted to bring into the conversation. It's an argument we hear a lot, to some degree, against DNA fragmentation. It's like, well, okay, you got the Comet assay, you got the SCSA, you got the Halo, you got ICD, you got all these different types of tunnel. So that's always been an argument against sperm DNA fragmentation. My personal view is, okay, but as long as you measure it in some way and measure it the same way each time, at least you've got something to work on. And there's nothing worse than the unexplained infertility diagnosis. Patients absolutely hate that. But I think this is an area we need to discuss, actually, is, okay, well, where do we put our peg? Where do we put our hat in terms of, okay, which assay? And assay, to the patients, what does that mean? It's just a test. It's a fancy way of saying test, isn't it? Which one should we be looking at? What are the important factors? And how do we then potentially standardise that in the industry? Is that something that we can achieve? Over to you guys.
Well, I think when you look at the history of DNA fragmentation, it tells us a story. Because unlike any other medical test, here were 4 or 5 different tests developed by scientists, not doctors. Now, when doctors recognize a test for rheumatoid arthritis, then it's in the nature of us doctors, our tribe, Tim, to go out and test it. And we'll go, as Mike was saying, to a drug company, get the money, and we drive it. With DNA fragmentation, it was driven by scientists who are completely different beasts. They were interested in their test, the science behind it, a spin-off from molecular biology. So each of those scientists that developed each of those 5 tests proselytized that test on the basis of its science. And also, because we're all humans, that they, as a professor of molecular biology, were better than the other guy who'd produced a slightly different test. And they had big personalities and they pushed it. And so we as clinicians, unusually, were left following the pack. And we didn't really know who to believe. And then if you add the difficulty of doing large numbers of tests in research unfunded by a company, then we get to where we are. I think that they all have their own validity, and I think that the most important thing is to try to stick to one test and not to retest people who've been tested by one methodology with a different test. So once you're comfortable with your test, then I think it has its own
validity.
It's almost self-serving.
Yeah.
But we've got ourselves into a mess.
Mm-hmm.
We've got ourselves into a mess because we've not quite known who to believe. That's us, not the people,
Mm-hmm.
but the doctors.
And that comes back down to education, doesn't it? And it's about knowing what are the differences between the tests and what do the values that the tests provide give an indication for, and what are you going to do with the management of those patients once you receive that result? Because there's always going to be a range, but you've got to collect your own individual knowledge about how are you going to manage this patient in conjunction with all the other data that you've actually been able to understand about that patient dynamic.
But I would ask Tim, in your experience, because I know you've done loads of these, would it be your experience that if we take unexplained infertility or idiopathic male infertility, which is probably about 50% of those turning up at a fertility clinic, then it doesn't really matter what test you use, it will be abnormal, that whichever DNA fragmentation test you choose.
Yeah, I think you're right. I guess what I was getting at more from a from a research perspective, trying to sort of move the knowledge in the area. It's difficult if you look at a research paper that's got, because the assays obviously whilst they're all measuring sperm DNA fragmentation, if they're doing it in a different way, I wouldn't say they're completely equivalent. There are differences there, and just from a research perspective, it's a bit messy to have lots of different, completely different ways of looking supposedly at the same thing. But one thing I think is very important is if people are going to be measuring sperm DNA fragmentation, that it's done in a very accredited, regulated, high laboratory quality way, because really the worst of all worlds is to be doing a test in a basement somewhere with a microscope in an unregulated and unaccredited or low accreditation way. So I think absolutely, if for any testing like this, sperm DNA frag, it's really important that it's done in a laboratory that has really put the time, money, and effort into getting full accreditation.
And how, from a patient's perspective, because they're not going to truly understand what's the difference between a tunnel, an SCSA, and a comet, and they don't probably know anything about accreditation and labs. They just they trust, and unfortunately, this is down to marketing, isn't it? To some degree, people out there potentially selling things, because they're just selling things. How are patients going to know?
That's down to the clinician in the clinic. I mean, really, doctors who are ordering tests, it's down to them to be using a good laboratory, an accredited laboratory, in the same way as if I suggest to a patient they go and have varicocele, whatever it might be. I want to send them someone like Jonathan, just not some random person I read about on Instagram. Ideally, it's someone that there's quality there. But the difference with DNA frag testing is there. I agree from a patient point of view, it will be probably almost impossible to find out accreditation levels. But from a clinician ordering these tests, I think it's beholden on us to make sure we do that.
Yeah. And what are you looking for then as a clinician? So as a gynaecologist or any gynaecologist that's working in an IVF clinic, think, okay, yes, we want to integrate DNA fragmentation. We recognise the importance of diagnosis and then treatment for the man. What are you going to be looking for? What are the tick boxes that you're going to want to see?
Well, I think just to know that we're working with a high quality service, and obviously there's you guys, examine.
Yeah, I'm not fishing, by the way.
No, we're not fishing.
No, I know that, but I think it is important. So if I was just made aware that there was someone who had started their own little service somewhere, I would be saying, well, what accreditation have you got? So I'd be looking at integrating it into a pathway that is resistant to challenges, that has a good service, good results, and also you can discuss the results with the lab as well.
Yeah, I think you make a very good point there, Tim, that you can discuss the results and understand where this is going. I've always tried to inspect the workplace, a bit like we do in hospitals. You turn up in a hospital to, let's say, to do an operation. The first thing I want to do is to have a look at the operating theatre and say hello to the people who run it. Yep. And just sort of get a feel for whether this is okay or not. And I think with DNA fragmentation, with all tests about a human fluid, but a dynamic human fluid that is changing with time, you have to understand what actually happens to the specimen.
Yeah.
How do they handle it? If it's going to be frozen, how quickly do they freeze it? Do they leave it around? Is it always attended? This always comes into accreditation, of course, as Tim is saying.
Yeah.
But actually with sperm, it's a bit more subtle because you've got to look after that specimen. It's not just the machine you use. It's the people who are handling it.
Yeah, definitely. And it all comes down to quality management, doesn't it? And that's what accreditation is all about. It's about quality management from start to finish, from requesting a test all the way through to the results delivery. It's do all of those steps that you expect a test to deliver, meet all the standards, the international standards, or the CE marking, or the registration with the local authority, whether it be the Medicines and Health Regulatory Authority or the HFEA. Does it meet all the standards that would be required for a physician to actually enable them to make a good diagnosis of the patient with that diagnostic test?
I think
so I agree.
that's probably such a big important takeaway for anyone listening to this, is if you're going to go and get a test, whether it's at an IVF clinic or an independent clinic, wherever it is, that you're armed with this information to ask these questions, because it's really important. You're getting information about your fertility, your future health as well, potentially. So it's important to ask these questions. You mentioned the HFEA there, Mike, and obviously Tim, you sit on a couple of committees with the HFEA. Does this sort of testing fall within the HFEA's remit? Because we do know that DNA fragmentation sits on their traffic light page, but is it? This is quite a big question potentially. Does it fall within their remit?
So the HFEA.gov.uk website there's a page there for those that don't know that looks at IVF add-ons, and essentially the Department of Health asked the HFEA before I was involved to look at different add-ons, to define what add-ons were, and then to rate them as to whether the add-on increases the live birth rate. So again, before I was involved, the sperm DNA frag came up as a question mark about whether it was whether it should be considered an IVF add-on and therefore should be rated. And at the time, it was felt it wasn't considered an add-on because it wasn't something that was done during an IVF cycle, was basically the reason for that. But it was felt that it is obviously it's an important test. There should be a comment on it, and so it is at the bottom of the add-ons page, and then there is a comment there about sperm DNA fragmentation. So it's not an add-on, but it is there because they felt that there should be a comment. I mean, whether it's within the remit of the HFEA, I mean, the HFEA were asked to look at add-ons, so I guess it is within the remit. But very importantly, the HFEA currently, at least, doesn't have any way of telling clinics to stop offering tests or anything at all. That is outside the remit of the HFEA. We can comment on stuff, but we don't have any power to stop tests being offered.
Because really, it's not actually an add-on, is it? It's a diagnostic tool, I suppose, really, rather than add-on. So
yes, but in the context, you see, I have sympathy with this, because in the context of what a fertility clinic, particularly funded by the NHS, is about, it is about live births. And I come back to my comment as if you merely look at a whole load of DNA fragmentation tests and then you look at the outcome, well, you're not going to see the difference that you might be able to obtain in an individual having made the diagnosis and having reacted to that diagnosis where you can. So it's not comparing like with like, but I have sympathy with the clear statement, which is that you will not improve your live birth rate by doing DNA fragmentation.
No.
Well, of course you won't, because you can't react in the time frame and within the funding envelope to the possibility, and I say possibility because we're having an open conversation, I think a probability, but let's just say the possibility that having known an individual's fragmentation, made that attempt at diagnosis and reacted to it, you can't improve that individual's outcome. So I have total sympathy with the position of the HFEA, but it's not actually looking at each couple. No. It's looking at the whole picture for what is now 35% of IVF and ICSI treatments, which is a big commitment. This is a big deal for the National Health Service. So I have sympathy with what they've done. I don't agree with it because it gives the wrong impression. But as a statement, it is reasonable.
I think just on the, because obviously DNA frag is a diagnostic test, but it's, so going back to the endometrial receptivity, that is considered an add-on. So that is a diagnostic test, but it was considered an add-on because what you do with the result is you change the type of fertility treatment. And that is also true for DNA frag, because clinics are using DNA frag to switch people from conventional IVF into ICSI.
That's right.
I'm glad you've raised that.
So that is very widely done, or even adding PIXI in. So whilst it's a diagnostic test, it is being used to change management during an IVF cycle. So it's pretty close to an add-on.
But that would be, would it not, Tim, in patients who have normal semen analyses?
Yes.
Now, of course,
yes.
there are about 12% who have a normal semen analysis and who have an abnormal fragmentation. Now, that group would actually be open to study purely on the basis of changing policy, which I don't quite know how much more it costs to do an ICSI compared with an IVF. So I get the implication of that, but it wouldn't be that many patients.
Yeah, so you're probably talking an extra £1,000 to £1,500 for adding ICSI on top of conventional IVF. So the pathway could be that you could have a couple with unexplained, in inverted commas, fertility. The guy has a sperm DNA frag test. So his semen analysis is completely normal, but so there's no indication for ICSI, which is when you inject sperm into the eggs. You do a sperm DNA frag, it comes back as abnormal, and then the clinic then says, okay, well, we think we shouldn't be doing conventional IVF, we should be doing ICSI. So that is an extra intervention for the eggs and for the couple, and an extra cost. But you could have you also can have a situation where the semen analysis is abnormal. The couple already having ICSI, you do a sperm DNA frag, it comes back as abnormal. Clinics are suggesting PIXI under those circumstances, which is physiological ICSI, which again can carry an extra cost, and it is an extra, maybe not extra intervention, because you're still injecting the sperm into the eggs. So this is situations where the result of a DNA frag test can actually change management during an IVF cycle. The question is, does it improve the outcome? And that's the bit that is unclear at the moment, because those studies, which actually wouldn't be that difficult to do, because you get away from the whole time question that, Jonathan, you were talking about, abnormal one, do you then do a varicocele treatment, you're then waiting months and months afterwards, which is difficult. But within an IVF setting, it's actually not that difficult to do that type of study.
Sure. And the question, of course, one's really asking, we're getting into a fairly high-level discussion here, is whether, in the case that Tim describes, does PIXI or some other method, advanced methods of sperm selection in the face of high fragmentation, override, for example, repairing his large varicocele?
That's right.
So we get into actually a very interesting area, again, difficult to interrogate. But the starting point, I would hold, is having that extra information. Because without the extra information, one is merely just reacting without knowing exactly why we're reacting. That's the bit that I rail against.
Yeah.
A bit.
And I think it's a really interesting comment that you make there, because there's a number of different interventions that could be possible by doing that additional test that may not have been done earlier in the cycle. So, we know, if we look at sort of the root causes of DNA fragmentation, there's a multitude of different factorial things that could crop up, from lifestyle, from nutrition, from occupation, and levels of exercise. But it could also be that there is an infection that hasn't been identified, because we don't routinely do, semen culture these days. We don't routinely do the MAR test, the sperm antibody testing. So there's a number of different diagnostics that are not necessarily done, but we need to understand what is that root cause before we're trying to fix it with different techniques that are often in the embryology lab's remit. And I think that's the big sort of dilemma, isn't it, really, is that we need to understand what is the root cause from research, and then apply the right methodology in treating that person, rather than perhaps just manipulating the sperm at the point of trying to get a conception. So, and I think that's really what we need to investigate a little bit more. But it all comes down to, I believe, a correct diagnosis right at the beginning. And in order to do that, we may need to apply more than the standard testing that is currently offered.
And we could go a little bit further. I hope we can go a bit further, which is to look at the different types of fragmentation. So to what extent, for example, I'd be very interested in Tim's view, being a proper scientist, as opposed to me, Tim, a hack clinician.
Not sure I'm a proper scientist. Not sure I'm even a scientist.
Well, having scientific tendencies.
Okay.
Okay.
Is that a compliment or not?
No, it is. No, it's a big compliment. It's a great compliment. It's a big compliment. So whether the type of fragmentation, whether it's double-stranded or single-stranded, actually influences, firstly, what we can do to fix it or improve it, and whether that in turn influences the outcome of the ICSI cycle. I mean, we do know that there is a preponderance of double-strand breakage in couples with recurrent pregnancy loss. And where the breakage is occurring in the genital tract has always fascinated me as a clinician. But do you think that the type of breakage makes any difference to outcome?
I think in terms of whether the type of DNA break affects the outcome or different types of outcomes, I don't know the answer to that, but I'm interested to know what you think, Jonathan.
I think it probably does. Intuitively, I think that double-strand breakage may be, firstly, more difficult to fix and may be an intrinsic phenomenon. And again, intuitively, if we're dealing with single-strand breakage, which is happening all over our bodies all the time, in all of our organs, but we have repair mechanisms for that, which is the argument, actually one of the arguments against measuring sperm DNA fragmentation, that this is something that you measure at a point in time, but had you measured it tomorrow, the body defenses would have repaired it. But I think that it is more difficult for those repair mechanisms to deal with double-strand breakage. And therefore it is more difficult for us to modify the double-strand breakage, whereas single-strand breakage improve the lifestyle, reduce oxidative stress, reduce heat stress. All of these things, it seems to me, are more likely to be effective for the single-strand breakage. So I have a tendency to try and go further, particularly with the couples who've got a very bad IVF ICSI history, few blastocysts, poor implantation of euploid embryos, which is another, I think, huge area of inquiry for us in the future.
I think that sort of indicates the power of the tests, I think, that are available, because as we mentioned earlier on, there is an array of different DNA fragmentation tests with different sensitivity levels at different levels. So we know from that point of view that there's a number of tests that will identify double-strand DNA fragmentation more robustly than single and double-strand breaks, which are traditionally measured together. So again, it becomes down to, in my sort of view, the appropriateness of the right test for the right patient, for the right sort of presenting conditions. And I think there's validity, as we mentioned earlier, between all the different types of tests of DNA fragmentation to one degree or another. And some will be very useful for a normal sort of sample that's a little bit idiopathic or unknown in fertility. But then when you get into nuances where patients have got very low concentration and difficulty in trying to conceive, you may have had one or two cycles which have not been as successful as what one would think and maybe have gone to ICSI, then it's about trying to explain what could that be, and looking at that DNA double-strand break may be more important to manage the expectations of the couple on whether they decide to move forward with another cycle, or look at what could be that root cause and maybe potentially changing their fertility journey options from that point of view. So I think they've all got a validity, and I think it's a matter of understanding what those tests are and where they differentiate from each other, and which is going to be more useful in the presenting conditions of that patient. I think that's probably what I would suggest.
Well, I mean, you raise the most difficult question, I think, as a clinician seeing couples, which is when to stop.
Mm-hmm.
And it's much easier, I think, for Tim and the reproductive gynecologist to be able to say, well, here we are. In the last 2 cycles, we're lucky to have got 1 egg. We can look at the female's birth date.
Mm-hmm.
We can look at the blastocyst rate over the last 5 cycles, and we're beginning to come to a pretty clear conclusion that on the female side, we've just run out of time. Now, the problem with the men, the male factor, is that here is the man who's still got, apparently, 5 million sperm, 10 million sperm. And it's very easy under those circumstances for certainly the patients, the couple, but us as well, to fall into the trap of, well, it only takes 1.
Mm-hmm.
But if, for example, a double strand breakage is at a certain level, there probably isn't 1.
Mm-hmm.
But we've never really been able to say that. So we get ourselves into, we begin, I think, because we're doctors and, we want to help, we can fall into the trap of colluding with what is happening here. We don't mean to. We mean to give proper advice, but we don't have the tools to do it, or as many tools on the male side as we do on the female.
No, I agree with that.
So just because this has got quite technical now, so poor old patients listening to this. Oh, crikey!
There was always a risk.
Oh, absolutely risk of that. Yeah. I sort of kind of want to come back to the point we were talking about ICSI as a potential treatment for got high DNA frag. I think our motto with Test Him is always let's do everything we can to optimize the sperm. And I think this then goes back to one of your sort of opening comments, Jonathan, of diagnosis. We run the test and then we look at all these other factors. I think that's got to be the important point here. Is it's rather than perhaps a couple going through IVF, we see we've got high DNA frag. Semen analysis is fine. We're going to do ICSI. Our view has always been, well, actually, what else can we be doing to optimise that man, rather than, like Mike said, manipulating the sperm. So do we think there's a better opportunity within fertility clinics and working with good urologists and clinicians to actually say, right, let's take this couple out of this situation, time permitting, because that is always the big thing, and say, right, let's take this guy out, let's get him seen, get him more thoroughly investigated, then treated, so that we optimise the sperm, and at least then we feel like we've given them the best possible chance. It's because I think you also said, Tim, like, okay, what do we do with this information? Does that not seem like actually that should be the sensible route in future?
Well, I think I'm always very keen for very early on in a person's fertility journey to discuss with them, lifestyle, all the things that have been mentioned already in passing, about optimizing weight, exercise, don't smoke, don't vape, just be sensible with caffeine, alcohol, etc. A nutritious Mediterranean style diet, all that sort of stuff, which is only going to be good for all of us, but also particularly from a fertility point of view, it's going to be good for eggs and it's definitely going to be good for sperm as well. And if people do have a sperm DNA frag result that comes back as abnormal, that's a discussion you have with them anyway to try and help the situation. So really, we should be saying that to everyone, not just people who've had a sperm DNA frag result that's come back as abnormal. In terms of then the other type of testing, again, I mean, Jonathan and I did a debate on this a few months ago, actually. Should most stroke all men have a sperm DNA frag test? And my view is no, they shouldn't, because there's just a lack of data that there's a benefit. And I think there's a risk of potentially over testing and worried well and all sorts of different potential negative aspects there. The difficulty at what point, how do you narrow it down? So, should DNA testing be possible at all? Absolutely. I strongly believe it definitely should be a test that is available. The difficulty is in which groups, what groups, and even sort of unexplained infertility. Well, if the woman's 40 years old, is that really unexplained infertility? Because there's an age factor there. So which group are we talking about there? Should all men go and see a urologist? I mean, it's great for private urologists. I guess if that was the answer to that was yes, but the reality is no. I think we need to be realistic that what proportion of fertility men should be going to see a urologist. There aren't going to be enough suitable urologists to be able to see to do that. And in terms of infection testing and microbiome, yes, under the right circumstances, but should all men be having that? No, would be my view. And that's just the unknown, and that's obviously this discussion we're having now. And I hope that with time we'll narrow that down so that we know which men should have the testing and what you do with the results. I think there should be more testing being done than there is at the moment. And but old jury's still out on a lot of this.
No, I entirely agree with Tim. And having been on the receiving end of that debate, I mean, it was a bit like Rishi Sunak. I went in with 50% of the votes and came out with sort of 6. But I think the reason that it went the way it did was because there was that word routine. So routine testing. Now, of course, routine means that you make it available to absolutely everybody. It means that it's probably off the shelf. It means that it's not being interpreted. It means that you're removing that bit of doctoring. And I would rail against routine. I'd almost rail against routine in every part of medicine, because then we have an unsolicited result which cannot be apportioned correct meaning in the context of the couple. So there's a lot of old-fashioned doctoring in this. And the mood of our young patients is very much against that. It's to go on the internet, to have a home sperm test, but really a home everything test. And my observation of that is that everything gets into a terrible muddle.
I think it does, Jonathan. And I think, just echoing both of your comments there, it's about appropriateness, isn't it? It's about appropriateness through that diagnostic sort of diagnosis. It's about, understanding that patient, understanding where they are in that fertility journey. And it's the appropriateness of any diagnostic test, not just DNA fragmentation. It's about appropriateness of any diagnostic test, regardless of whether it's been researched by the patient and said, do you think this is a good idea? Oh, I would like to have this test. It's about, actually, is that appropriate? Is it medically appropriate? And can I interpret the results appropriately to make the right medical intervention following that? So I would argue that it's quite right. The routine part is going to be really difficult. Appropriateness is absolutely probably the most critical thing to do, as long as the physician understands what that test is trying to do and knows how to interpret the outcome of that test in conjunction with all the other information that they hold about that patient. So it's always about appropriateness to me.
And I think there's a big deal here really about us trying to re-educate. It's not a question of educate, but re-educate all our colleagues in primary care, because there is a gap there. I vividly remember what happens when you completely remove primary care, which of course happened during COVID. And I had several patients who were phoning me up weekly, having done twice weekly home sperm tests with hugely varying results. And these poor men were driving themselves bonkers. Now, you could argue that they might have been a bit bonkers to begin with, but this was for the absence of a proper considered input at the beginning. And I think we've disadvantaged our colleagues in primary care, probably actually, because certainly speaking for myself and possibly Tim as well, we didn't educate that cadre of medical students properly. There was not much that was fertility based, virtually nothing in urology, and I suspect not that much in gynecology either, because we go back to 65% of the treatments being in the private sector.
I think it's a reflection of some of the guidance that's out there. We mentioned NICE guidance earlier on. And, NICE guidance can only really be influenced by new research. And I think that's what, as a company we're interested in doing, is in improving the amount of knowledge about data from research, and then revisiting those guidelines, or from a consensus point of view, if we can't actually do the level of robust meta-analysis and Cochrane-type review data that would change NICE guidance, it's about almost then thinking about, well, what could we do from a consensus viewpoint by reviewing the data that we've collected, and does it make sense to change our view, and does that then change the education of new medical students coming through about newer thought processes about how to manage patients through their fertility journeys?
And I guess if we don't do the test, if we don't do some of the interventions, if we don't look at these men, we then don't get the data. If you don't get the data, you don't influence the guidelines. Nothing moves forward, does it?
Yes, but there are not very many guidelines actually for primary care.
No.
So the bloke has a semen analysis, and the poor GP or whoever's interpreting it, and of course it could be the receptionist, hasn't got a clue what this really means.
No.
There hasn't been a discussion about the simplest aspects of male fertility.
Mm-hmm.
It's often left to the laboratory that does the semen analysis to just say, retest in 3 months
Mm-hmm.
for a variety of reasons, one of which is sort of go away. And so we're getting off to a bad start because that bloke feels lost,
Mm-hmm.
and therefore his partner feels lost. So if I had a great big grant, I'd sort of go off into general practice in my dotage and rant at the poor GPs about the meaning of male fertility, the meaning of a semen analysis, because I think that would be a great start.
And where do you think, just bringing it back to that appropriateness of what we're talking about here really is advanced male fertility tests or more advanced tests, where do you think that is then from, you've got that primary care, basic semen analysis, the referral through to gynecologist, IVF clinic, and then eventually leads on to IVF. Where do you feel DNA fragmentation might sit in that pathway? Which is quite a hard question given we've said there's so many variables, but what are our thoughts on that?
Well, in my practice, but now, of course, I'm not in the NHS. So in the NHS, I would see a man who has a delay in fertility with an abnormal or indeed normal semen analysis, and without the ability to do a DNA fragmentation test in the NHS, in the urological clinic, I would take the view that if this is a clinical varicocele, we measure it at over 3.5 millimeters, and he's young and he's at the beginning of a journey, better treat it than not.
Mm-hmm.
Of course, being able to do a DNA fragmentation, particularly with a normal or near normal semen analysis, and that would be abnormal with a delay to conception, then of course we got the ticket to do the varicocele, certainly with a measurement.
Mm-hmm.
In private practice, young man with varicocele right at the beginning of his journey, he might not have known he had a varicocele, but he's at his beginning of his journey, and there are more of these couples turning up sooner rather than later, then I would measure his DNA fragmentation, unexplained infertility, and use that not only as a baseline for subsequent improvement, but also a reason for treating him.
Mm-hmm.
Now, if you're asking a different question, which is here is a couple a little bit later in their journey, they are relatively young, and the semen analysis, same semen analysis, normal, near normal, then I can quite understand and would entirely condone having a run at IVF or ICSI. Why not? We get a lot of biological data that stands a reasonable chance of working, so that's that varicocele or not. But then biological data from one cycle, and it's not good, particularly in terms of blastocysts, then I would like to see a DNA fragmentation.
What about you, Tim? Where do you think it might sit in that pathway?
I guess it's I think with any test, as I mentioned earlier on, it's just really important that the patient is aware of the advantages and potential disadvantages of a test and the uncertainty around a particular test that they're paying for. So my feeling would be that in a situation where a couple have come into a fertility clinic, by definition, by that time they're already probably 12, 24 months, whatever, down down the line and they're looking for an answer, I think it is entirely reasonable to discuss with them, and I presume there's a normal semen analysis, it's entirely reasonable to discuss with them the possibility of doing a sperm DNA frag, but I would also say to them the uncertainty over exactly what the result might mean. So I think there is still some uncertainty there in terms of what do you do with that information. If their lifestyle has already been optimized, we'll come on to supplements maybe in a second, but they're not. Do they all get sent off for to see a urologist or to have scans for varicocele at that point? Again, it's a really interesting area. Again, still relatively understudied in terms of effects of varicocele on improving live birth, but I think in the current NICE guidelines that are coming through, quite rightly, there's a much more urology involvement and looking at varicocele. I was on the last NICE guidelines committee 13, 14 years ago that led to the current NICE guidelines, and really there was a bit of urology input, but not a lot. It's fair to say. And so that
they've completely separated it out this time, haven't they? Varicocele.
Say again, sorry?
They've completely separated it out this time. The NICE guidelines, so they're under review at the moment whilst we're recording, and they've taken that male sector and they're doing that separately next year. So that's good.
So I think so I would just, because patients are paying a few £100 in general for a sperm DNA frag test, what I wouldn't want to have happen is it comes back as mildly abnormal and the patient says, "What does this mean?" And I go, "I don't know what it means." We're not really sure what it means. So I think it's after discussion with them in terms of them making an informed decision about having it. If it comes back as abnormal, then yes, this is what it will lead to, maybe paying for an ultrasound scan of the testes and going on and seeing a urologist or not. And
I think that's a really important term, informed decision. Something I always, as an acupuncturist, I'd always sort of coach my patients. So you've got to go and do your research and understand what you're doing. I think, Jonathan, go back to your point, you sort of, when we talked about that pathway and when you would do this, I think that really highlights that a test like sperm DNA fragmentation, and many of these tests, whatever it is, male or female, it's got to have that medical oversight. It's got to have somebody who can take that whole picture of the woman's age, what other factors are going on for the man, and you've got to bring all of that together because there is no right or wrong, is there? There's no, okay, yes, everybody needs to have it, because you've got a couple, like say she's 40, he's got confirmed varicocele, her AMH is on the floor. That's not the time to do a DNA frag and a varicocele repair because you're going to lose a year. But you've got to have that medical input, haven't you?
That's absolutely. I think you really summarised things very well there, because I think often what happens is, quite rightly, particularly nowadays, patients do their own research. It would have been difficult 15 years ago to do your own research, but now it's all there. The problem is there's so much rubbish out there as well by people just putting stuff on Instagram that it's I don't even know who's writing it and where they're getting their lack of information from. So often what happened when I see, and the same with Jonathan, when I see couples, very often they've had information input into their heads from all over the place, and whether that's relatives, mother-in-laws, who knows what.
They're not just to go on holiday, so
and I think that is the if they see someone who if they see a fertility urology clinician who is able to draw everything together, because it's unusual that there's a smoking gun, a silver bullet that you can just say, fix this, do this one thing and everything will be sorted. It's the pros and cons of spending 6 months going off down a surgical route, but then the woman is 6 months older. If she's 40, 41, that might be a really bad idea. If she's 30, 31, that might be a really good idea, because then you're buying potentially increased fertility for years and years. There's, for instance, a varicocele that's been repaired. So it's all those conflicting decisions that very often it's helpful for a couple to be able to speak to someone who has a high enough level overview of things, a helicopter view of things, to be able to bring everything together. But in the end, the couple make the decision, but an informed decision.
Yeah, absolutely.
Of course, it's interesting, isn't it? From what Jim just said, and I couldn't agree more. For the health of the nation, humanity, we need to get onto this early. And if we were onto it early, then of course the relevance of DNA fragmentation would be far less. Because just as Tim's saying, you would do some simple treatments for the man, maybe, but on the other hand, those young eggs will fix that single strand breakage.
Absolutely.
And so we then are not in this terrible conflict of how many cycles of IVF in the late 30s, early 40s are we really going to do? And I think it's partially because of that we're having this discussion, in fact. So if we could get out there, get to primary care, proselytize about the whole business of fertility, not just DNA fragmentation, then we might even be teaching ourselves out of a
Out
job.
of business.
Well, that's a great problem to have, isn't it? Really,
Yeah.
it's a great legacy to leave.
Oh,
Isn't it?
I would love to leave that legacy that we're not needed.
Yeah.
You know, it's kind of something Toby says. You know, we don't want any couple or any man to be going through this, and if we can avoid it through good education, the right interventions at the right time, that may, like you say, Jonathan, may be minimal. That's job done.
Yeah.
And I kind of think, you know, in some ways that's an IVF clinic's role as well. If they can do all the right things by the couple and help that couple conceive naturally, they've actually done a really, really good job.
Yeah.
I think, you know, you've touched on a huge issue here of education, you know, what's going on in society, you know, women, now a decade older than they used to be in terms of starting their families, got their careers first. We've got the environmental toxins, plastics, all of that. So there's so much to this that's way beyond a DNA fragmentation test, isn't it? So I think we're kind of coming to a natural close, but I kind of want to give you both a chance to, I don't know, do you have a summary, not a summary statement, but, you know, anything?
Can I just ask something else?
Uh-oh. Yeah.
Okay.
So if I should mention beforehand, so the role of supplements with abnormal sperm DNA frags. I'd be interested in your view, Jonathan.
So I think it's a really big issue because there's so many supplements and because it's so easy for couples to buy them, and it's not, well, it's almost like Panadol. You know, if one takes your headache away or doesn't quite, we might have 2 or 3. But of course, the trouble with the supplements is that you might add a whole basket load in your attempts to improve yourself, which might then cause reductive stress. So the straight answer is I always look at the level of oxidative stress, either by a MyOxis oxygen reduction potential test, the little easy one, or by a chemiluminescence test. And whatever they're taking, then you can judge at least whether they're taking too much, which I think is the most important thing. If they've got high levels of oxidative stress despite the antioxidants that they're already taking, then I say you must keep going, because without these antioxidants, you'd have a very high level of oxidative stress. So I think there is a measurement that we can do to guide us. But I certainly wouldn't be minded merely to be saying to all men, you should take supplements, or of course you should take supplements, because I know what will happen. The one supplement, which might be fine, will turn into 3, plus a whole load of other things, which also include vitamin C, vitamin E, and so they rapidly get reductive stress.
I think that comes down to testing again, doesn't it? It's about doing the right tests at the right time to influence the right decisions.
And the right baseline, isn't it? If you've got a baseline and you know what patients' diet and lifestyle is all about, well, then you can decide whether supplementation should be appropriate or not. But if patients are already on supplementation, then you could probably have a baseline test and say, well, actually, I don't think you should be on.
All of that. I think there's a question about what's sensible from the word go.
Exactly. Yeah.
And the answer is probably not that much, other than a good, nutritious diet, actually, because you can eat a whole load of antioxidants that are easy to buy in the supermarket, which aren't in a box.
Yeah. I think the other argument there is looking at the data that's behind some of the supplements. There's a whole range of supplements out there. There's a whole range of fruit and vegetables out there as well. I think adopting a good, healthy lifestyle is number one, and that includes just nutrition, what you buy and what you eat at home. But having a baseline to understand whether you still have oxidative stress, you may be insufficient or deficient in antioxidants that you can't absorb naturally from your body. And that may be the appropriate route of taking a supplement. But it's then about what is the science behind those supplements, because there's a lot of supplements out there which are apples and pears to measure, but there are some good clinical trials with some supplements that can show they actively reduce oxidative stress and improve DNA integrity. I wouldn't say reduce DNA in fragmentation, but improves DNA integrity or supports DNA integrity from when it's produced. So it's about, again, appropriateness, isn't it? About, the decision to test, first of all, and then it's a matter of working out what is appropriate for that patient.
But a carrier bag full is, in my view, almost always inappropriate.
Exactly. I would absolutely agree.
Does that answer your question, Tim? Or was it more about the appropriateness of antioxidants or supplements to treat DNA fragmentation? Or if there's confirmed DNA fragmentation, should men be taking supplements? Was that what you were getting at?
It's both, really. I mean, we should all men be on, as Jonathan's view, which I think has been very clear with the answer, should all, because obviously all women who are trying to get pregnant should be on folic acid and vitamin D. Yeah. There's not the same general recommendation for men. So I was interested in Jonathan's view on whether all men should be on some form of supplement, or then, as we just spoke about, whether it's a more narrow group where some testing has been done and shown an abnormality. Thinking of that big trial where men were on zinc and
selenium,
zinc and folic acid, zinc and folic acid. Huge big American trial there. The zinc and folic acid or placebo, and in the men with zinc and folic acid, the DNA fragmentation abnormality level went up. So, which comes back, I think, to Jonathan's example there, that even though zinc and folic acid, particularly zinc, is thought to be really good for sperm, whether it was the zinc or the folic acid that caused the problem, but there was a statistically significant increase in the level of sperm DNA frag in men on that compared to placebo.
But of course, it might have been what they got in their bathroom cabinet, their secret supplements.
But it was a randomised trial, and that was placebo. So that the other stuff that was being taken would have been the same in both groups.
Oh, that's very interesting.
Yeah.
Yes.
But I think it comes back to what you said earlier on about routine, testing or routine supplementation. I don't think there should be any routineness of it at all. You need to have a baseline understanding of what's going on before you can make a recommendation of whether to supplement or not. So I think supplementation can be quite dangerous, as Jonathan said. So.
I think we're in danger of launching a whole other podcast episode here.
Well, maybe we need to come back and do another one.
Gents, I think it's been a great conversation. I hope those that are listening have enjoyed it and have learnt from it. I still would like a closing statement from both of you, if you can give us a snapshot, an overview after today.
Well, I went first at the beginning, so I think Jonathan needs to go first at the end.
So, a good discussion. Closing statement says that we are reaching a bit of a consensus. The word routine for DNA fragmentation is not necessary, because that actually skews the thing the wrong way. But the need to appreciate precisely the clinical picture with every couple, and the sooner the better, will lead to some of them, probably the majority in different circumstances, eventually having advanced testing, of which DNA fragmentation is one.
Brilliant. Thank you. Tim?
So I think I look forward to more data. There will be over the next few years. Sperm DNA fragmentation testing is a really hot topic at the moment. So there are trials going on. There will be trials going on. There will be more data coming out year on year in this area, and I hope that it shows that there is an absolute place for sperm DNA fragmentation testing more widely, because I think a really good, strong diagnostic test that leads to better outcomes on the male side is very, very important. And I think discussions like this can only help raise the profile of that.
Yeah. Well, brilliant. Thank you both so much for your time, giving up half your Friday. It's been a brilliant discussion.
Yes.
There's loads more information on our website. Head over to testhim.com. We've got various articles on DNA Frag. We've had a couple of podcasts and YouTube Live on it. Yep. So check them out and reach out to us if you've got any questions. But thank you very much.
Cheers. Thank you very much, gentlemen.
Thank you.